Well, thank you so much again for having me. So just a fun fact about me, I'm married, I have 3 children. I used to do general OB/GYN before, was very passionate about delivering babies and everything, also still keep in touch with some of those some of those patients. And I'm very passionate about gardening. So you see, I'm taking pictures of things that I grow and things I harvest. And I recently became an Aggie dad. So I have my son going to A&M.
Dr. Pancholy, I just have to interrupt. I'm so sorry. I have to say, woo, that's all I can say.
Anytime, gig 'em. So I'm going to talk about pelvic floor disorders. So what are pelvic floor disorders? These are the conditions that happen, when women have weakness or tears in either the muscles or the connective tissue that is keeping the surface of the pelvis and supporting all these organs in the pelvis. So, but when these organs get weak, it can lead to either bladder control problem or bowel control problem, or actual herniation of those organs, so which would be like loss of support, and then also difficulty with the function of those organs. One of the functions the vagina has is sexual function, so it can lead to sexual dysfunction, and also pain syndromes that can also occur. So why are we just a little brief just anatomy lesson here, so basically the pelvis is a bony structure, and it's made of the pubis, which is the front where the pubic bone is, and that's the front of the pelvis. What we sit on is the ischium, the bottom part of the pelvis, and on the side where the hips we can feel the bone is the ilium, and all these bones fuse to form this bowl-like structure. And on the back of that structure is the lower part of the vertebral column, which is the sacrum, or where our tailbone and everything is, and where all the nerves exit. And these nerves then, interact with the organs in the pelvis and then go further down our legs to help us walk and everything. And the picture on the bottom you see is the pelvic floor. And so in a woman's body, this structure is a little wider to allow for childbirth and everything. And this structure is lined with all the muscles that we see in this photo, and the connective tissue and the nerves and everything. So that is what then supports all these organs that are in the pelvis. And it's when these muscles relax, you're able to evacuate the contents of your bladder or your bowel. You're able to have sexual intercourse. And in general, these muscles always stay in a good tone. So, to help you stay continent of your bladder and your bowel also. So this is just a little brief, anatomy lesson. And so why are we talking about, pelvic floor disorders today? And the reason for that is because pelvic floor disorders are much more common than we hear about. So 1/3 of all women, and more than 50% of women over the age of 55 suffer from pelvic floor disorders. And this could be anything that could be bladder issue, bowel issue, weakness in the tissue that's causing a bulge, which we call prolapse issue, or sexual dysfunction or pain issue. So it is pretty common. The data that people study as far as prevalence and everything shows that almost about 44 million women by 2050 are going to be suffering with one or more pelvic floor disorder. And this is something that I see or hear a lot from patients, that they don't really talk about the issue because they always equate that with needing surgery. So it's always that, well, I have that problem, but I don't want to have surgery. And so I put this in here because, we have a lot of non-surgical ways of managing this issue also. So only about 1 in 5 women actually will require surgery for this condition. What is the prevalence of this pelvic floor disorder in GYN cancer survivors? So there are some papers that have looked at this also, and so it ranges anywhere between 34 to 50% of women who have been treated for cervical or uterine or ovarian cancer reported some sort of urine incontinence problem. 1/3 of women reported urine incontinence to be more stress related, and we'll talk about stress incontinence a little bit more in detail also. About 1/5 of women, reported urge-related incontinence, where they have a gotta-go problem. Like when the urge hits them, they need to find a bathroom real quick, and sometimes it might be a problem that they don't make it to the bathroom. So, but 10% of women report having a vaginal bulge. That's that hernia that I talked about earlier. That weakness in the tissue then leads to herniation of, the bladder side of the vagina, or the top of the vagina, or the back wall of the vagina, and which is called prolapse. And this is something that's important because 1/3 of women say that these symptoms are not something that they're not bothered by. This is something that is really bothering them, as they consider their symptoms to be either moderate or of severe degree. So I definitely think that this is something that should be talked about and brought to the forefront a little bit. So what is the data specifically in ovarian cancer survivors? So there was a systematic review that was done that looked at, that kind of pooled all the data from different papers and everything. And they looked at prevalence of stress incontinence was anywhere between 32 to 42%. Urge incontinence, the gotta-go problem, was anywhere between 15 to 39%. And the pelvic organ prolapse problem was about 17% prevalence. And as you can see, sexual dysfunction is very prevalent. Anywhere between 62 to 75% of patients reported, having this problem. And we see a range, here of, it's not really like one number. And it's because, a lot of these studies looked at these using, looked for these issues using different definitions. So somebody could have used a questionnaire to find out if a patient has incontinence or sexual dysfunction, something like that, versus somebody could have done an interview and found out. So using different measuring tools does lead to kind of a little bit of heterogeneity in the data that we see. But so I think that we definitely need to talk more about it, and hopefully there's more studies that gives us even more insight into these issues. So what causes these issues, specifically in ovarian cancer survivors, or patients who have had ovarian cancer? And one of the main thought process, was from these papers was that maybe it's just the intra-abdominal mass effect. The same thing that Overcome, has talked about beach, some of the symptoms, with the, it's that kind of like pressure, building because of the cancer, causing actual, pressure on either the bladder or the bowel, or it could be the vagina. I personally have seen patients who presented with a vaginal bulge and found out that they had ascites that was actually pushing that vagina out, causing that effect. It could be the hypoestrogenic state, either from menopause or from removal of the ovaries that leads to the menopausal status. And then this hypoestrogenic state then causes irritative symptoms of the bladder, or it can cause dryness in the vagina that leads to pain and dyspareunia. So body image, having undergone surgery can have a significant impact on the body image. And this is one of the thoughts that that we saw, like it was a very high prevalence of sexual dysfunction, and we think that this body image plays a big role in it. And nerve injury, there are a lot of nerves, not the major ones, but really small nerves that are around some of these, these organs. And having, such a radical surgery, for cancer sometimes can lead to, some kind of a nerve dysfunction, which could lead to then pelvic floor disorders. So unfortunately, women will continue to suffer in silence with these pelvic floor disorders. A lot of these pelvic floor disorders are still considered taboo to openly talk about. But again, this is data that has been taken from women, asking them privately, and they, a lot of women, 70% of women reported that urinary incontinence is a major issue, and they worry about that, when they're out in public, about having an accident or having to cross their legs, anything like that. 35%, women have reported that they avoid activities, things they enjoy. Could be working out or even intercourse or something like that. That would just because of loss of incontinence. of urine. 62% of women, said that they waited before they talked about their condition, and 17%, of patients reported that they waited even longer, 5 or more years. And this has, been looked at in the G1 oncology data also, that 42% of patients reported pelvic floor disorder, but only about 7% of them accepted a urogynecologic evaluation and referral. And part of the reason for that was also that they were already undergoing treatment for the ovarian cancer, and didn't feel that this was a priority, and that's also understandable. How does this? So let's talk about urine incontinence a little bit. How does urine incontinence, impact quality of life? So what we're talking about, all of these issues are very different from what Dr. Zeri and my other colleagues, talked about, with ovarian cancer. This is more about quality of life. This is not, life-threatening issue. But I'll talk about how it does impact so much, on different levels. That having an incontinence, can lead to somebody, who has to wear pads all the time, which then leads to skin irritation or skin breakdown, if they're elderly patients and, who already have thin skin on their vulva. And so, improving the incontinence helps them reduce, or even not have to wear any pads. Patients are embarrassed about their condition. They socially avoid having to, get together with their friends and everything because of odor issues. And this is just urine incontinence I'm talking about. We'll talk about fecal incontinence also. That's even devastating than this. So these things then lead to more of social isolation, that leads to depression. And, so this is not something that, it's a little bit of leakage, it's that little bit of leakage issue that can have much more, bigger impact. So it should be something that needs to be asked about to patients. And then, or if your provider is not asking, then definitely bring it up, So many women, unfortunately, don't seek care, and they continue to suffer in silence. And so my goal today is to definitely talk about this topic openly, so, we can have a discussion. And we've seen a lot of, other things that women suffer from and everything like that. But I know that as provider, this is something that I'm very passionate about, that we need to be asking our patients about, about this all the time, that, are you dealing with these issues? And, if so, what can be done for that? We can offer them treatment. So these are some fun slides. So this is an old, issue of Cosmopolitan. And I say old is because it's, Drew Barrymore now, I think she has her own talk show, and she's a little bit older now than, what she is in this picture. And there's a lot of other headlines, that you see on the cover of this magazine. But if you look at it on the bottom left, there's a small little headline that's related to urgency and frequency. They talk about, do you always have to pee? And it says, find out why your tanks, it seems so tiny, and surprising ways to fix it. So I am a little curious, what they were talking about as far as ways to fix it. This is also another cartoon image talking about 2 different types of incontinence. These are the 2 main types of incontinence. On the left of the screen, we see, a woman who has loss of urine with physical activity or with coughing or sneezing, which we refer to as stress urine incontinence. And on the right, we see, a woman who has an urgency problem, who has a gotta-go problem, who has to run to the bathroom either frequently or sometimes doesn't make it, which we refer to as urgency urine incontinence. This is one of my favorite slides. This talks about, that I laughed so hard the tears ran down my leg. And this is an example of stress urine incontinence. This topic did get a little bit more notoriety when we see people who are more on TV talk about their problem and then what they did for it and everything like that. And so here's a clip of what Linda talked about, that she could not jump on trampoline. She was like, I'm fine, when I a couple of times, but the third one, then it's over. Just she has incontinence. And she, in this interview had talked about that, the treatment that she went through and everything, and how much she had improved. So So it's really good to see people talk about this openly. So what are the treatment options for incontinence? Earlier I mentioned everybody has this idea that, oh, it's going to be surgery, and I really don't want to have surgery. So I kind of wanted to go, over some of the non-surgical options. So very first thing is just behavioral therapy. We know there are so many things that are bladder irritants, caffeine in high doses, artificial sweeteners, certain citrus products, and things like that. These are all things that can irritate the bladder. And so, when there's a higher dose of it and not enough water, sometimes that will lead to, the bladder muscle having, twitches or spasms and lead to having urgency and frequency and those kind of symptoms. Training that bladder again to be able to hold better is also something that can just, it could be as simple as that, and that takes care of the problem. Now it's easier for me to sustain that. It's not that easy to do. So I'm a big believer for physical therapy. I think pelvic floor, specifically pelvic floor physical therapy, is something that is not, talked about or offered to our patients. If you look at our colleagues in Europe or Australia, New Zealand, all those countries, most women after having a baby is referred for pelvic floor physical therapy. And this is just something that we just don't do that in the United States. But again, that is something that is changing, and hopefully we'll see more and more of it. But pelvic floor physical therapy is significantly beneficial. And so I would say that that's something that, can be, that can be the only treatment that the patient needs, and then they're good. So weight loss is very important. We have, good science, data that shows that 10% weight loss can improve bladder symptoms up to 40%. So weight loss is very important. Smoking, any of these pelvic floor disorders that I'm talking about, the incontinence, the prolapse, anything like that, smoking has always been shown to be one of the culprits. So definitely quit smoking. And then we have a lot of medications that can help calm the bladder down, so that way that you're able to hold urine better and not have as many accidents. Our data definitely does show that when these therapies are used in combination, so physical therapy with retraining the bladder, with using that medication as a crutch to help get a better control of that bladder, does lead to a better outcome. So I would recommend using combination therapy rather than just doing only one thing, only the medication or only physical therapy or something like that. So there are a lot of minimally invasive treatments for patients who have tried all these things, that come in and say, I've been doing, Kegel exercises forever, nothing works. And, then fine, if they have good muscle strength and they still are suffering, there are some other, options that we can, talk about. And then surgery, obviously anything major surgery should be the last option. So what are some of the treatment options that are invasive? On the bottom, I don't know if it's hard for me to see if you can see my arrow. So this is a sling, a picture showing a urethral, mid-urethral sling that's placed to help with stress incontinence. That's the coughing, sneezing, and leaking type of problem. And then these treatments on the top, shows different treatments that can target nerves that go to the bladder, that if you use a pacemaker, kind of a device that controls the nerve activity, that helps regulate the nerve activity and get better control of the bladder. On the top right is a acupuncture treatment that is used, where the acupuncture needle has been stimulated with a small amount of current, kind of like a TENS unit that gives you tingling up and down your leg, that targets the nerve also, which then retrograde works back to the bladder and helps calm the bladder down and helps with incontinence and urgency, frequency. And if none of these things work, then we use products such as Botox. It's a very potent neurotoxin that has been used for wrinkles and things like that. A lot of women are familiar with that, but we use it for the bladder because that helps the bladder just calm down and that muscle from having too many twitches. So urine incontinence doesn't have to be something that's part of normal aging or something that happens after having kids or after having treatment or surgery for your cancer. So it's very important to get the right diagnosis, to be on the right path for treatment. And I'm sure as cancer survivors, everyone knows that this is critical. And also know that there are a lot of options. that are available. And it's very important to make the right decision, something that fits your lifestyle, because this is, at the end of the day, this is about your quality of life. And it's very important that you have control to be able to live your life to the fullest. So I'm going to switch gears and talk about prolapse now. Prolapse is something which is weakening of the tissue, then that leads to sagging or drooping, a kind of feeling in the pelvis, or some women actually might see or feel a bulge in the vagina or even out of the vagina. And then that, can then lead to bleeding that can happen if, the tissue rubs, with their underwear or pad or something like that they're wearing. This picture just shows different types of prolapse. On the rectocele on the top left of the screen shows the rectum side of the vagina that's falling, and then the rectum behind it will also droop, and that little pouch will lead to stool getting trapped there, and then it's hard for women to either evacuate stool, or later on, the stool that's trapped there can then seep out, causing fecal incontinence. On the top right, you see the photo with the bladder and a little bit of the rectum, falling down, and then that can lead to either incontinence or retention problem. And then the middle picture on the bottom shows everything just falling out: the bladder side, the rectum side, the uterus. It's basically the vagina has just turned completely inside out. And so what causes this? There's so many things. We talked about the menopausal, the status that leads to lack of estrogen. Genetics play a big role, or the type of work. I mentioned I enjoy doing gardening. If I'm doing a lot of lifting and things like that, and I have weak pelvic, muscles, things can lead to that prolapse. And so that's a picture that the bridge showing that that the support structure can weaken and then can lead to that bridge falling. And then childbirth. Childbirth is vagina does provide that outlet, but the childbirth itself does lead to stretching of that tissue and weakening or tearing of that muscle. So, and then we talked about smoking causing this. So the key is you're not alone, dealing with this issue. So a lot of women have these, problems. And then, like I said, so many, women have this problem, but they don't talk about it. So don't suffer in silence. There are a lot of treatment options. Prolapse, depending on the degree of the prolapse, can be managed just with expectant management. You can just say, if it's very mild, which most women actually have, who have had even 1 or 2 children vaginally, then you can just monitor it. You can just say, okay, let's keep an eye on it. As long as it doesn't get worse, it doesn't have to be, treated. Excuse me. Weight loss, like I said earlier, does help. Pelvic floor muscle exercises. This physical therapy is critical in these organs working, and also how they coordinate with these other structures in the pelvis. Pessary is a scaffold sometimes that we use to lift everything up. So it can be some non-surgical way. It's a great option. It's been used for centuries. That's something that helps lift everything and then support things back where they belong. And then surgery. There's lots of different ways of doing the surgery: vaginal, laparoscopic, robotic. With COVID, actually, most patients even go home. It's not even an inpatient stay, and they do well. Surgery is an option. Here's a picture of different types of pessaries. Like I said, pessaries have been used for centuries. These are some of the common ones that we use. In the interest of time, I'm going to speed up a little bit. So what is the goal of the surgery? That, we want to fix all the defects at once. If there is a bladder side defect and there is some on the rectum side and the uterus is falling down, or if the top of the vagina is falling down, we want to go ahead and take care of that all at once. We don't want to come back 6 months later and then fix another defect. We want to make sure that vagina has a sexual function. So we want to make sure that the axis, the caliber, the length of the vagina is also maintained, and not, have any constriction rings. I'm going to switch another gear and talk about fecal incontinence. Now, this is the one that's extremely devastating, as anyone can understand. This is something patients definitely don't talk about, and a lot of people don't ask about it also. The prevalence, again, because it's not talked about that often, we don't really know the exact prevalence of it, because a lot of people don't even report it, even if they're having this issue. But it has been reported in about 12% of GYN cancer survivors, compared to only 1% in the control group, and studies looked at it. So it is pretty common, and it's not a normal part of aging. So this is not something like, oh yeah, this is happening, because I got older, or it happened after I had kids or anything like that. And it is the second most common reason that, patients get admitted to nursing homes, because after, dementia, this is the second most common, where it's hard for caregivers to take care of somebody who has this problem. So again, there are treatment options available. There's lifestyle modifications and physical therapy. Again, this is first line treatment, fiber and physical therapy. That takes care of most of the issues. If that doesn't work, then that pacemaker that I showed with for urine incontinence also helps with bowel control. If that doesn't work, then you get to surgical options, either anal sphincteroplasty, or if somebody has had really bad damage to that area and it's not fixable, then sometimes they might require diversion. I'm going to talk about sexual dysfunction also. I put this picture because, if somebody's suffering from these pelvic floor, disorders, and, having to wear Depends, or, has a complete E version of the prolapse, and I apologize, I don't mean to gross anyone out, but, the body image completely changes, and this person is not going to feel like wanting to be, intimate with someone if they're dealing with these issues. Again, we talked about how, ovarian cancer survivors we've seen, and even other GYN cancer survivors, that, this is sexual dysfunction is a major issue. This is a paper, that looked at a lot of patients reported having dryness in the vagina, and about 62% reported having pain and discomfort during penetration, which is called Dyspareunia, and that's also most likely related to that dryness. So there are other, the conditions which are like incontinence and everything that leads to this higher rates of sexual dysfunction. So it's very important that we address everything. This is just a little bit of a Dyspareunia cycle that, with penetration, if there's that dryness and everything, so that patient might feel that initial pain, and then that pain is, becomes a fear. And so then next time they're, if their partner wants to be intimate, that fear then, leads to anxiety, and then, they're not in the mood to have intercourse, then leads to more dryness, and then that causes more of the muscles tensing up, and then causes spasm, which then again leads to that same pain with penetration. So we want to kind of, target everything. There are conservative ways of managing this, just not,
Dr. Pancholy, I'm sorry to interrupt you. You have about 2 minutes
yes,
left in the presentation. Thank you so much.
Absolutely. I'm going to speed up right now. So yeah, so again, there's lots of different conservative ways that we can take care of this. There are a lot of medications that also help with this. And then putting the estrogen back in the body, which is safe, then, we can make the vagina well estrogenized. And there's a lot of different, products that are available. I put a picture of this coconut oil because, it's a great lubricant. Astroglide, I'm not really marketing any of these, but these are different lubricants that are non-hormonal, which are also treatment options. Lasers have become quite, popular, but I just put this out there that, they are still not something that is the standard of care for this, for the dryness in the vagina. So the conclusion, these are pelvic floor disorders are very common. They're very treatable. They do significantly impact the quality of life, and I definitely encourage everyone to seek care, talk about this with their provider, and just make sure that their physical therapist or their provider has done specific training to be taking care of these issues.